Good morning. In this video, I'll talk about the fusion, also known as arthrodesis, between two bones called the talus and the navicular. The talus is a bone that forms the ankle joint located between the two malleoli, while the navicular is the bone immediately in front, as you can see in this illustration, where the talus is colored green and the navicular is colored red. The main indication for this procedure is advanced osteoarthritis, a term used to describe the wear and tear of the cartilage lining the joints. Osteoarthritis can be primary, when there are no specific causes other than the natural aging of tissues. Secondary osteoarthritis, as the name suggests, is a consequence of other conditions such as rheumatic diseases, foot deformities such as severe flat foot, avascular necrosis, a condition in which the blood supply to the talus or navicular bone is reduced or even completely cut off, or as a result of previous trauma involving one or both of these bones. Surgery is commonly performed under general anesthesia, known as narcosis, or better yet, if possible, under spinal anesthesia, which means an injection in the back. The latter has the significant advantage of significantly reducing pain after the operation. The first part of the procedure involves identifying common anatomical landmarks to limit the length of the skin incision, which is typically about 6 centimeters. We typically identify the medial malleolus at the ankle level by drawing a dotted line to identify the posterior tibial tendon. Above this line, I've drawn another line, which will be the one I'll use for the skin incision. The skin incision is progressively deepened layer by layer, also coagulating the small blood vessels to ensure a perfectly clean operating field. We now arrive at the articulation between the talus and the navicular bone. Before reaching the actual joint, we must cut the joint capsule, as you see me doing now. Once the capsule is opened and spread apart, we can easily see the part of the talus positioned on your right and the part of the navicular bone, which is clearly visible in this magnification, on your left, as I try to represent in this diagram, in which the talus is colored green and the navicular bone in red. At this point, the more aggressive part of the operation begins, which involves using sharp instruments, like this curved chisel, to scrape away the last remnants of cartilage, which in this case has completely disappeared. The use of the curved chisel is alternated with the removal of the remaining fragments at depth using this surgical instrument called a luer. In some cases, where the surface to be removed is harder and more sclerotic, the curved chisel must be combined with the use of a hammer to remove these particularly stubborn areas. These surgical procedures are repeated until a layer of well-bleeding bone is reached, which will allow for good healing, facilitated in some cases by harvesting bone tissue from the pelvis or below the knee. These areas of the body are rich in stem cells, and the harvested bone is used to fill any irregularities that may have occurred during the preparation of the worn joint surfaces. Each of these small bone fragments is then inserted with surgical forceps into the cavity between the talus and the navicular bone. Over the weeks, this area will gradually fill with new bone. Since this bone graft is rich in stem cells, it can be beneficial for healing. At the end of this operation, the talus and navicular bone are brought together for what is now the final phase of the procedure: stabilization with metal fixation devices, which in this case are shape memory metal staples. You can imagine them as staples 2 centimeters wide and deep that are inserted into the bone after a tunnel has been drilled. These staples have the advantage of having a certain degree of elasticity that they maintain over time, thus allowing constant compression of the bone surfaces, thus promoting the bone's healing within a reasonable time. Once inserted into the drilled bone tunnels, the metal staples are hammered until they come into contact with the surfaces of the 2 bones. We repeat the same process until the required number of staples has been used. In this case, I decided to use 3 for ideal stability. In this drawing, I try to illustrate the position of the staples, shown in yellow in relation to the talus, colored green, and the navicular bone, colored red. Finally, we perform final X-ray checks using a low-emission X-ray device which confirms the correct position of the metal staples. Immediately after the X-rays, we wash and clean the wound and then proceed to close the superficial soft tissue in layers until the skin closes. After surgery, we apply a cast or a long boot with the foot at a 90-degree angle for the next 6 weeks, thus avoiding putting your foot on the ground. You will therefore need to use 2 crutches to walk. To reduce the risk of deep vein thrombosis, low molecular weight heparin injections are required. Heparin injections are painless and safe, unlike the anticoagulant tablets that many patients request for convenience, but which in reality can cause more problems. I myself admit that it can be unpleasant to think about giving yourself an injection every day. To be clear, I will tell you right away that heparin injections are not painful at all. To prevent swelling, it is necessary to keep your foot elevated when sitting or lying down. The stitches are generally absorbable, and therefore, there will be no need to remove them. They will fall out on their own. At the end of the 6 weeks, after having performed an X-ray, you can begin to put your full weight on the ground as long as you use a protective boot for the following 2 weeks. After seeing what surgery entails, you're probably wondering how painful this type of procedure can be. To reassure you, I'll show you the same patient whose surgery you saw, who is now in her room the next day and on whom I'm giving her the first dressing. As you can see, she can move her operated foot quite well without pain, even without protection, while the same patient, immediately after the dressing, shot from a different angle, he has no limitation in moving his entire lower limb after having replaced the cast I mentioned earlier. As with all surgical procedures, there are potential risks, such as delayed or even failed healing of the bone, called pseudoarthrosis, which may require a second operation, infection, deep vein thrombosis, persistent swelling, and a long recovery time. Since the surgery is aimed at blocking a major joint in the foot, you may also experience persistent stiffness that could make walking on uneven surfaces difficult. All of these aspects should be discussed with your surgeon before the operation. Thank you for your attention and for your support.